Can we have the chairpersons for the next session? I'm informed that Dr. Shefali Tyagi will be arriving a little late actually. So we have the two chairpersons, Dr. Beena Jaising. And Dr. Beena Jaising is a highly respected gynecologist in Bangalore with over 2 decades of experience in the field. She works at Manipal Hospital, Sarjapur Road. She's a senior consultant Obgyn. She's a broad spectrum of expertise including high-risk pregnancy and gynecological procedures and laparoscopic surgery. She's a graduate of the prestigious Madras Medical College. So she trained in gynec laparoscopy from Germany. She has published articles on gynecological topics and a member of several professional organizations. Next slide, please. Dr. Sriprada is a consultant in minimal invasive surgery in gynecology at Apollo Hospital and Cloud9 Hospital, Bangalore. She is the executive committee member of BSOG. She has a fellowship in minimally invasive surgery at the Bangalore Endoscopic Surgery Training Institute and Research Center. She is MD from All India Institute of Medical Sciences. She is a senior resident at Postgraduate Institute of Medical Research and Chandigarh. She is also an undergraduate from St. John's Medical College, where she was my senior. So welcome you both, and over to you, ma'am, for the speaker introduction.
Yeah, thank you. We all do face, we all increasing number of thyroid disorders in pregnancy. Today we have Dr. Saptarshi talking to us about difficult thyroid cases in pregnancy. He's a senior consultant at Indraprastha Apollo Hospital in Delhi, and he's an executive member of the Endocrine Society. He's an ex-president of Society for Promotion of Education in Endocrinology and Diabetes. He has more than 90 publications in various national and international journals. Welcome, Dr. Saptarshi.
So I think it's a very, very common problem, having thyroid disorders in pregnancy, and we see both the spectrums, hypothyroidism as well as hyperthyroidism. So, and you can't always label as hyperthyroidism. It's sometimes thyrotoxicosis only. Just a minute. And pregnancy itself also causes some thyroid changes in the physiology. So we have to interpret each and every results of thyroid related findings in the context of pregnancy in most of the cases. So my topic is, do you have the slides? Yeah. Difficult thyroid cases in pregnancy, and so I will start with basics. So sometimes even simple things can get difficult. So these are the basic physiological changes in pregnancy. So you have like an increase in HCG, which causes which increases thyroid production from the thyroid gland. So that causes raised FT4 and TSH suppression. So that will, for most of our patients, if somebody is having hyperemesis gravidarum, it's a very common coincidence. So T4 goes up, TSH goes down, but that is a normal physiology. As of now, there is no recommendation to treat that condition. So sometimes we have patients who are very frightened. T4 has gone up, sir, mera range was 12, the T4 is showing 15, so I have a thyroid problem. So that is not the case. So T4 increase because of an increase in TBG, because of increase in estrogen is a normal physiology in pregnancy or OCP. So that also occurs, but the total T4 will increase, the free T4 will not increase. Also, there is increased iodine requirement, there is increased peripheral T4 and T3 degradation, decreased thyroid antibody levels. So the good thing about it is that somebody is having some autoimmune condition, pregnancy has a modifying effect. The most of the autoimmune conditions tend to settle in the second or third trimester of pregnancy. So that is something which is helpful in otherwise a very complex situation related to thyroid and pregnancy. So we start with a very simple case. So we have this lady who has a low free T4. If you look into the report, so free T3 is normal, free T4 is slightly low, and TSH is normal. So this is called isolated hypothyroxanemia in pregnancy. So do you actually need to treat it or not? So even though there are studies that which suggest you need to, there is an association of adverse pregnancy outcome. As of now, whatever RCTs have been done till date, they have not shown a benefit of giving thyroxine in these patients. So there are associations with preterm birth, premature rupture of membrane, increased risk of GDM, fetal distress, but we have not been able to prove that if you get an isolated free T4 in pregnancy, you treat it, and first of all, it's very important that you rule out that it's not an assay error. It's very common that the free T4 assays which are commonly used, so they tend to be slightly underperform. So the free T4 values tend to get low. Total T4 values might confuse you, as I started with, that they tend to be slightly on the higher T4 lab value. You need to multiply it 1.5, then take it as, so if the lab says that 12 is a normal cutoff for the total T4, the actual cutoff will be 18. But even in that context also, so if 15, if it's more than so if it's less than that, so you actually need to be careful. So you need to interpret in that context. But considering the assay fluctuations, you really need to be careful about T4. So mostly the assays, as I told, they tend to underperform, and you need to consider the assay. So total T4 is actually a reliable assay if you are applying the cutoff of like 1.5 times for an increase in TBG related to pregnancy. Having said that, so we go into the next case. It's a very, very common situation. So a patient comes totally apprehensive. A TSH is 100, 200, 50, 60, 30, 40. Sir, the gynecologist has told, should we continue, should we not continue, what is your call? So we will discuss that situation, and a TSH of 139, low FT4, TPO antibody is elevated, conceived, and so at maybe 6 weeks, 8 weeks, 10 weeks, they have come to you, and how do you actually tell them how to go about it? So we all know that in the initial half of pregnancy, it is the mother who supplies thyroxine to the baby. So obviously that is required for fetal brain development and subsequent neurodevelopmental function. So if there is hypothyroidism, also the one common context we see is that the increased risk of abortion. So if somebody comes with a very high TSH, so there is a chance of miscarriage. So that can happen. So that is like the nature's own cure. But other than that, so there are some other complications also. But what the most common complication we see is a neurodevelopmental outcome related concern in the mother or the parents for in pregnancy. So this was a very landmark study which was published long back in 2002 or 3 in NEGM, and this is something. So the patient will actually ask you, sir or ma'am, do you want, should we go for a termination, should we continue, what should we do? So first of all, my personal concern, my personal opinion is that we should only counsel and give them the risks and benefits information, and we should not give them whether they should terminate or not. So we had patients, somebody just 1 month back came from US, they had not advised a thyroid as information, got a thyroid done, was pregnant into 6-7 weeks of pregnancy, and the TSH was 150, 160. So this happens to all of us. So what we need to understand is how to counsel them. Obviously, the concern related to the risks, that cannot be, you can never tell that, okay, this is going to be fine, or there is going to be a problem. So first of all, there is not a major risk of congenital malformation. The major risk is related to the neurodevelopmental progression in the baby. So this was an NEGM study which I said was published in around 20 years back, and they followed up children who were having, so there was one group of women who had normal TSH, there was one group of women who were having hypothyroidism, they had a pregnancy and their TSH was above the normal range. There was one group of women who did not have pregnancy, have hypothyroidism diagnosis before pregnancy. So this is like 3 diverse group of people, women who had pregnancy. You can look into the women with hypothyroidism and control women. The baseline TSH was 13 in the in women who had hypothyroidism and who were taken in the active group. And this is old study, but I just wanted to share with you because it's very, very relevant to our actually clinical practice and how we share information with the patient. The control group only had a TSH of 1.4. So most of the parameters, if you see that if women had TSH more than, so the mean TSH you saw was 13. So most of the parameters, so that didn't do that well. So if you look into the parameters, so many of them that didn't reach statistical significance. The children of 62 women had high TSH, and they did slightly less on almost 15 tests of development related to the neurodevelopmental parameters. So the full scale IQ scores of children were 4 points lower. And what is more important is that if you look into specifically, so there were 2 groups which are specifically analyzed. So if children had hypothyroidism, if the women had a diagnosed case of hypothyroidism before pregnancy and was slightly undertreated, had an accidental pregnancy, TSH was not normal. So in those particular cases, actually the outcome was not that bad. But in those cases who were undiagnosed and had somebody comes to you with a high TSH, actually the long-term follow-up, if you see, so that was slightly worse than what we normally expect. So specifically, if somebody is having hypothyroidism and gets a TSH which is pregnancy, which we always recommend that if somebody is having hypothyroidism, you need to get a TSH before conceiving, and also you need to get a TSH as soon as you conceive. We need to increase the dose. But if you have an accidental pregnancy and you have a TSH and it comes out to be range of 14, 15, so still it's reassuring that the results don't show that it's that much of a problem. But obviously, if somebody has a TSH of say 15, 20, 30, 40 and comes to you with a pregnancy, so that is something. There is some risk of neurodevelopmental anomaly. It's not an anomaly, you can say. The IQ scores and all, they go down by 4 or 5 points. It's not that the children are retarded, but again, the risk related to it has to be taken by the parents. Your job is only to inform the pros and cons of continuing the pregnancy. The initial dosage, as you all know, will be like 1.6 microgram per kg of body weight, and so that is also, and you need to titrate your thyroxine dose to keep it below 2.5. So 0.5 to 2.5 is the target TSH in for pregnancy. So that is out. So 0.8, 0.9. So you don't decrease the dose. So that is how it should be. So you have to you can be reassured that this is normal. And even if you start thyroxine and have a TSH which is normal, please document that you have explained the risk of whatever the complication is if the TSH is high. So that should be in your prescription. So if somebody comes with a TSH of say 100, 200 or whatever value you have, so it's a difficult thyroid case, so we tend to spend maybe another extra 5-10 minutes, but that you have spent, you have counseled, you have reassured the patient, that should be documented in the prescription. I think that is something which is very, very important. That is something which should be done. And this lady was started on 125 microgram, and the TSH came down to 0.81, and that is how it should be continued, and that is how the prevalence of overt and subclinical hypothyroidism is. So I am not going to go into the details of it. So this is another situation. So we have a lady, 7 weeks pregnancy, got a routine test done, TSH 3.28. So what do? So we do a TPO antibody. So that is how, so we don't treat it. We see cases that 3.21 and they have straightaway started on thyroxine. So as of now, the recommendations for treating hypothyroidism in pregnancy are more or less simple. So if it's less than 2.5, you don't need to treat. 2.5 to 4, you get a TPO antibody done, and if that is positive, then you treat. More than 4, you treat in most of the situations. So there is no confusion in it. We see patients who have a TSH of 3.99 or 3.6 who have been a TPO antibody has not been done, and somebody has been started off thyroxine to 12.5. Again, that is not the correct way to go about it. So you need to get a TPO antibody 2.5 to 4 borderline TSH in pregnancy. You need to get a TPO antibody and then only treat. So this is another situation. So somebody comes to you, had recurrent first trimester abortions, and the TSH is 1.84. but TPO antibody is strongly positive. Should you treat or not treat? So what we see is that there is a risk of pregnancy complications, including abortions, if the TPO antibody is elevated. So that is what even meta-analysis suggests. But again, what we see is that if you are actually, this was a study which was published in Lancet 2022. So if you are trying to replace thyroxine and for that, so you don't have anything else for thyroid disorders. So TPO antibody, you don't give steroids, you don't give immune modulators, you don't do anything else. But if you are trying to replace thyroxine in this particular situation, so what this study which was published in Lancet Diabetes and Endocrinology in 2023, so what they showed was that it actually doesn't help. So this is a gray area. So first of all, if you have a TPO antibody which is positive, and and there are recurrent abortions, so even though there is a risk, as of now we don't have an answer to how you can actually correct that risk. So these are the conditions related to hypothyroidism that can cause confusion and sometimes can cause difficulties. And we now move on to a very simple case. So the topic was a difficult cases of thyroid disorder, but I thought that we will discuss the simple cases and move on to complex situations if you have any queries. 32-year-old lady plans to conceive, clearly elevated hyperthyroidism, confirmed by scan and TSH receptor antibody to have Graves' disease, started on carbimazole, and TFT was monitored. So there are some patients who are lucky, their thyroid dose, anti-thyroid medication dose goes down. There are others who are not that lucky and they require a higher dose of anti-thyroid medication for maintaining euthyroidism. So after 8 months, she was among those unlucky 20-30%. If you can take that as a value, that there can be problems. So the T4 was just euthyroid on a 20 mg per dose, and she wants to conceive. So we have 3 options as of now. Surgery we hardly do now. So we unless somebody has a suspicious nodule, so we have radioiodine as a definitive option for hyperthyroidism. So we do not offer surgery unless somebody has a concern-related malignancy or somebody has a huge goiter and is having compressive symptoms. So in most other cases, the choice is between anti-thyroid drugs and radioiodine ablation. So what radioiodine ablation does is that will obviously convert it not to euthyroidism. So if you are offering radioiodine to somebody, the point is that they have to be counseled that there is a 90% chance of progression to hypothyroidism, and that is how it should be counseled. So if you so that is one option, or you can continue with anti-thyroid medications. So if you are offering radioiodine, again the problem is that, so if somebody is planning a pregnancy, the TSH receptor antibodies, which is which does not, I'll show this, pass on to the baby, which does pass on to the baby, so that will still be there. So if you have a situation where the mother has been offered a radioiodine, so one thing is that you are not offering radioiodine because of the radioactivity related concern, but the other aspect is that you also have a condition that in Graves' disease, because it's an autoimmune disorder, the TSH receptor antibodies are elevated. So if you are offering radioiodine, so that remains high almost till a year or so. So that gradually goes down. So if you have a situation that the mother is hypothyroid because of radioiodine, you have an elevated TSH receptor antibody that will pass on to the fetus, and you have that complex situation where the mother is hypothyroid, the baby, because of the TSH receptor antibody, is actually getting stimulated and is hyperthyroid, and you need to give thyroxine to the baby, and maybe that is the only current situation. Block replacement regimen was professed in UK for a very long time, those who have practiced in UK, but it is not recommended anymore. Maybe that is the only situation you can offer a block replacement regimen. So for most of the situations, you will either continue with anti-thyroid medication. For those who can delay their pregnancy for 6 months or 1 year, we can offer radioiodine. So again, the prevalence is like 0.5 to 0.2%. So it's the uncommon variety of thyroid in pregnancy, and there is actually a beneficial effect of pregnancy on hyperthyroidism or Graves' disease. So we know that pregnancy has an immune modulating effect. So as pregnancy goes on, the requirement for thyroid medication actually goes down. Anti-thyroid medication actually goes down. Unlike hypothyroidism, where as pregnancy goes on, so the requirement for thyroxine might go up slightly. Some patients come, why is it going up? Why my thyroxine requirement is going up? So it's the contrary. So it's an immune modulating effect of pregnancy, and you need to be sure that if somebody is planning to conceive, whether you want to give carbimazole, methimazole or propyl thyroxine, that has to be understood. We have a timer somewhere? Okay. So propyl thyroxine used to be the choice of medication for pregnancy throughout, maybe another 10-15 years back, but there is a major issue with propyl thyroxine related to the development of adverse side effects related to liver hepatic toxicity. So it can cause fetal acute liver failure. So you need to give propyl thyroxine for a very, so there are advantages. So if you are comparing propyl thyroxine versus methimazole or carbimazole, so most of us will be using carbimazole. So if you are comparing the two, so as far as fetal toxicity, fetal teratogenicity is concerned, so propyl thyroxine it scores better over methimazole or carbimazole. For otherwise, methimazole or carbimazole is a better drug, so that should be preferred. So if the 88 2017 guidelines, if you go into that, they suggest that if somebody is coming to you with a planning to conceive, so as very regular periods, you can straightaway you can shift to propyl thyroxine if the requirement for anti-thyroid medication is high. If otherwise, you can shift to, you can continue if somebody has a PCOS also and you are not sure when that person is conceived, is going to conceive. So you can continue with methimazole, carmimazole. So the idea is that you should be giving propyl thyrosol for the shortest duration possible, but you have a benefit of teratogenicity related to the other two medications. So that we all know. So we should be avoiding them in the first trimester. So whenever, so the person can continue with methimazole or carmimazole. Whenever they conceive, you need to stop it immediately. So that is what 2017 guidelines also tell. And whenever the lady conceives, you stop. If you can maintain that, so you don't look at TSH after the lady is conceiving. So you are not monitoring TSH, you are monitoring T4. So if you are able to maintain the T4 in the high normal range after conceiving, so and without antithyroid medication, you don't need to add it. So this is something which is quite contrary to our personal belief. Everybody is the person will come with, TSH is very low, I need to baby ko koi problem to nahi hoga. So again, so your monitoring parameter as soon as the lady conceives is not the TSH value. You don't want to make the TSH in the normal range, because that will, if you are doing it, if it's being done automatically, that is good. But if you are doing it with medication, if somebody has a high requirement for antithyroid medication, if you are making the TSH in the normal range with high dose of antithyroid, so that can cause fetal hypothyroidism, and that should again be strongly avoided. So PTU is the preferred drug.
So Dr. Saptarshi, you'll have to buy time.
Just 1-2 minutes. So PTU is the preferred drug. If after 12 to 14 or 16 weeks of pregnancy, you shift to methimazole or carmimazole. So that is again the FDA's advisory is, and shifted to, so this lady was shifted to PTU 200 mg per day, and after conceiving we monitor with T4, that's what we already told. And so that is what the FDA advisory is also. And so sometimes we have issues related to fetal surveillance also, and that is something we need to be careful. So if usually detecting a fetal goiter is a very, very complex radiological procedure. So not many gynecologists or radiologists will be able to do it. So you really need to be careful if somebody is having that. So there is one situation. So since Anand Raman told me you need to discuss complex cases, so one situation you are really stuck if somebody develops a agranulocytosis with any of these medications. So most probably in that case, second trimester thyroidectomy is the only solution you have if the Graves' disease is very overt. Most of the children do, the infants do quite well with, even if the mother is taking antithyroid medications, you don't have an issue. And these are the common pitfalls in pregnancy. So don't mistake a high T4 value as a total T4 value specifically as a abnormal finding. So that has to be, the T4 correction is 1.5 times. TSH sometimes it goes down because of commonly in settings of hyperemesis gravidarum, even in pregnancy. Again, you need not treat in those situations. And if you have any confusion related to thyrotoxicosis, that okay, now the TSH is low, T4 is high, and the mother can actually be having a thyroid related issue, you get a TRAB antibody. Otherwise, in all other cases, we get a thyroid scan done, but we can't do it. And most of the immunological disorders other than hypothyroidism. So if some lady is having hyperthyroidism, that is pregnancy is going to help. But in hypothyroidism is the contrary. So all immunological disorders settle down in pregnancy apart from hypothyroidism, where increase in dose requirement is natural. Thank you once again. Be very careful about postpartum thyroiditis also. So that can occur till 6 to 8 months after pregnancy. So T3, T4 can go up, TSH can go down, usually settles on its own. So you need to be careful. And I again want to thank Dr. Anand Raman and Magna team for this opportunity to share my views on thyroid and pregnancy. If there are any questions, I hand it over.
Yeah, I think we'll take the questions at the end, sir.
Okay, thank you.